Please enjoy the show. I hear it's a breath of fresh air, but with 2.5 micron particulate matter.
Paul,
I mean, you can edit that out, right? That doesn't have to be there.
they'll get the joke in 20 minutes or 30 minutes when that comes up.
Just like I said before, put that in your back pocket and just savor it until the moment comes. You'll know it, and then you'll just nod knowingly with a smile on your face and a song in your heart.
It'll fester. Podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moore Hospital and affiliate outreach programs. If indeed there are any, in fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong. Welcome back to the Curbsiders.
That's right, Stuart. And what a show it was today. We just keep doing this, apparently.
That's right. Paul, what do we do exactly? Why don't you tell us?
We did this already?
I think we should introduce ourselves.
Yeah. I'm trying to ignore Matt.
Okay. Maybe Paul and I can turn the tables on you.
As per usual.
This is Matt Watto. This is the Curbsiders. Stuart Brigham is the one that is derailing the show as usual, as he tends to do. And this is another recap show. We are in New Orleans at Chest, #Chest 2019.
That's right.
And we have a lot of great pearls today. We had 3 great guests. We'll tell you about them in a second. But Paul, remind people, what is it that we do on this show? And maybe if you wanted to tell them the meaning of life, why are we here?
Sure.
That would also be appreciated.
Sure. No problem. So we are the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And again, we have another lineup of just spectacular experts. You'll be hearing from, yet again, from Chest at 2019, as the great Dr. Watto said. Meaning of life, is it 42?
Yes.
I guess so.
I was actually looking that up just now.
So with us
42.
again, who has been fantastic at this entire conference, helping us make sure that we keep on track with everything, is the great Sarah Phoebe Roberts.
Hi.
Sarah, can you tell us about our guests?
So we were joined today by a group of phenomenal pulmonologists, including Dr. Aaron Nareski, Dr. Chima Melton, Dr. Nina Malanen, and
our good friend, Chief Resident at Walter Reed, Kim Fabian.
That's right.
And we had a very wide-ranging discussion yet again. We talked about some end-of-life stuff. We talked about vitamin C. That was quite entertaining.
That was something else.
Spirited.
We actually talked a little bit about how religion ties into patients who are critically ill. We talked about DOACs and reversal agents, lung cancer and small particles, some procalcitonin. Everyone always loves to talk about procal. And some teaching pearls, augmented reality, and what happens if you drop a computer in the middle of a small remote village. It was yet again another wonderful conversation that we had here at Chest. And I should once again thank the great Dr. Bill Kelly, who was kind enough to invite us here. Him and his wonderful team have been so accommodating, and we'd like to thank them for having us at Chest. We are humbled and honored.
Yes, thank you, Dr. Kelly.
Aaron, yesterday we were talking about this in pre-recording, but we didn't have time to get to it. So I want to talk about the end of life stuff that we learned at this conference. Can you tell the audience what you're excited about there and some tips that they can use in their practice?
Oh, I would love to. I think the best part of the session, which was called Dealing with Requests for Futile Care, was provided by Uluba Canola Dwyer. She's a lawyer, and she was able to talk with us about some of the case history regarding end-of-life care issues in the ICU. And so one of the things that she taught us that I had never heard before, but which makes total sense, is that no legal method has ever been successful in having a physician or institution held liable for not providing futile care, even when that care resulted in the death of a patient. So the only legal standard we're actually held to is the malpractice test, which is the same test we're held to for all of the care that we give, which is that physician treatment decisions are measured against the standard of care, and that requires that substandard care had to have caused injury to the patient. So as long as you're providing a standard of care, you don't need to offer futile therapy because the legal system says that we have to. And I think that's a broad misconception among our colleagues.
Now, we had kind of discussed this a little bit there, but there could have been some selection bias behind that too. That doesn't mean you can just, run around and just say everything's futile.
No, and one of the things that was discussed in the meeting was that we should really not be using that term very frequently.
Right.
Instead of saying futile, if we think that care is unfortunately not going to result in a good outcome, we should say potentially inappropriate and medically ineffective.
Right.
Which is a nice keyword that I'm going to just tattoo on the inside of my wrist so that I don't forget it.
Yeah. I love that.
On my tombstone.
I love that
That would
phrasing.
be very applicable, Paul.
We have to remember that language is an intervention in itself, and the way that we frame things for families makes all the difference. During the session, one of the case studies that was talked about was, a very moribund patient with multiple strokes, and the question that was raised to the audience was, what do you say to this family when they ask you for a trach and peg for this patient? And one of the people in the audience just raised his hand and said, who told them about a trach and peg as an option? And it's a good point. The language matters, and the way that we roll things out really matters. It helps save people a lot of suffering.
Yeah.
I think a lot of it depends on the modeling that people are exposed to. And since it's historically something we haven't done a good job at, we now have to start catching up and do a better job of that.
Yeah, I think one of the conversations we had, and I think which Stuart referred to about selection bias, is I think we've all probably provided not futile care, medically ineffective care at some point. And I think I just wonder if those protections are because those patients were just the sick of the sick. And I guess what I'm saying is, I think if that was applied to every patient for whom futile care was applied, I'm not sure. I wonder if the numbers would be the same or not. I'm not sure what I'm saying makes sense.
Yeah, no, I completely agree. I think, though, that it is worthwhile for us to think about it from the front instead of the back. Instead of going to a patient and saying, can we please not provide futile care?
Yeah.
We should be providing the standard of care and justifying what the standard of care is, and talking with people in a compassionate manner that is honest about what the medical care we can offer can provide for them. So it's a little bit like asking forgiveness and not permission, but it's in a compassionate and thoughtful way.
Yeah. One of our recent guests, Dr. Josh Wee, talked about, I guess this hasn't been released yet, but he talked about making wish statements like, I wish I had something better to offer, but unfortunately, when I've tried this in the past, it hasn't worked.
Right.
So I thought that was really good.
It's almost a cop-out when you give unrealistic expectations, or at least you leave the semblance of unrealistic expectations. So someone brings up that trach and peg, and you're like, I don't really want to fight this fight, or that's a negative connotation behind it. But this is not something I'm going to be able to convince them of. That's what you've said in your mind, and so you go ahead and acquiesce to that. But then you're giving them an unrealistic set of goals and expectations that you're not pulling that veil back on. Which
reminds us all that we have to elicit goals right at the start. What are your goals for care is the first thing we need to talk about with patients and families when they enter an ICU setting, because then we can frame our future discussions in terms of what will meet their goals. We can say, I know your goal is to have your mom at home, and unfortunately the interventions that you're discussing with me are not going to meet that goal.
Chidinma or Nina, anything to add to this about the end of life stuff that you wanted to say?
Absolutely. As someone who sees patients both from an inpatient perspective as well as outpatient with my chronic pulmonary disease patients, having that conversation from the get-go is really crucial. A lot of residents and fellows tell me, oh yeah, I'm meeting the patient for the first time. It's not the right time. But you know what? You plant that seed when you see them in the ER or when you see them on the floor, and you open the door and start asking these questions, because the next time they come in to see me or their oncologist or their primary care physician, you're more open to talking about it, because often these discussions are a journey. They're not a destination in themselves.
We also have systems issues that we all need to address about that. Out-of-hospital DNRs often don't translate into the inpatient center, so we all need to be advocates in our institutions for smoothing the systems that make that possible.
One point I wanted to add with regard to discussion, they actually had a very interesting session this morning with regard to religion and end-of-life care. People usually try to shy away while talking to the families and bringing the religion into the discussion. And it has shown actually that trying, even using your own experience and trying to relate to the other family, even if you're not really familiar, whether it's one of the monotheist religions or any other religion, that it helps put everybody at ease and accept more, really, let go. And they discuss specifically the example of brain death, and brain death of pregnant, patients that actually end up having to lead or continue the care until the baby is delivered. And that's a really difficult situation. So I think, we tend to forget about including religion in the, discussion at the end of life care.
I'm sorry. And what does the introduction of religion look like? Like, did they give you sort of examples, or how do you actually introduce that as sort of an initial discussion?
So the discussion, the way they explained it is always use yours, even if they are, because you have no idea what the patient's family and what their beliefs are. So try to relate to them based on your own beliefs without imposing your beliefs onto them, which is very difficult to do. But
right. What if, and I'm not being funny, what if you don't have one necessarily? Like, then how do you sort of proceed from there?
Then you learn more about the patients, and you ask them, do you have any belief system? And we tend to see this also in the chronic illnesses, as far as how aggressive you end up going, whether it's the IPF or whether it's the end of life care in oncology situations. And I think even if you do not know the patients or the families, if you learn more about their religion, there might be a better pathway to try to relate to them, to get them to understand that it is a, really, I don't want to use the word futile, but it is really something that should be made, that the patient needs to be made more comfortable rather than, intervene.
And potentially inappropriate and medically ineffective.
That's it. I will tattoo it too.
And just to jump off that point, I think we've stirred away, appropriately from the paternalistic way of practicing medicine. But at the same time, we are physicians, we're clinical practitioners, we know more than the patients do. And often they're seeking guidance from us. So we shouldn't be afraid to take a stance. Often patients ask me, what would you do if this was your mother?
Right.
What would you do if it was your dad? And I tell them honestly. And in some cases, they don't ask me, but I volunteer that. I tell them from my knowledge, from the patients I've seen, this is not going to work out well. There's a very high likelihood that your father's going to pass away from this condition, and we can make his time here more painful. There are interventions we can do that may not work out the way we expect them to and may prolong his suffering. So there are certain keywords you can use in having these conversations that tell a patient what's going to happen, but in a very sort of soft, kind way, empathetic way, that doesn't minimize the suffering that their loved one is going through. So don't be afraid to take that stance and offer your expert opinion, because that's what it is of how a patient's going to fare.
Having said that, don't run down to the ER the first time you see a patient and have absolutely no thoughts about religion. Just walk up to them and say, what are your thoughts on dying?
Yeah.
That's probably not the best way to start a rapport.
You should probably say, hi, I'm Stuart Kent Brigham.
Now,
first.
what are your thoughts on dying?
I want to move on because you all have a bunch of other great stuff to tell people about. So Dr. Nareski, what would be the next point you wanted to make?
Well, I attended a really interesting session, which was regarding bleeding in the ICU.
Okay.
And the use of thromboelastography to minimize transfusion while providing an equivalent outcome and standard of care. I really think this is something that all of us can advocate at our institutions, because most of our institutions do have TEG as an option. Mostly it's used in the operating room setting. But if we can kind of grab that for ourselves and take it into the ICU, we can provide fewer transfusions and equal outcomes.
So TEG, can you just give the audience like a quick, what is it, and how practically how would it be used? Because it's not something that I've ever used before. And maybe if you're a hospitalist, you're seeing someone come out of the ICU trying to read about what was done. It's just good to know about these things that are being done in other levels of care.
Yeah, so TEG is a point of care test. It tests the efficiency of blood coagulation, and it's primarily used by surgeons and anesthesiologists. They take a small sample of blood and they rotate it gently through a spinner 6 times a minute. And what they do is they measure how fast the clot forms, the speed and strength of the clot formation. It's typically measured by a computer, and you get all of this in a printout at the end of the test.
Yeah. And how would that potentially change what you're doing based on the reading you get?
Well, unlike a lot of other tests of coagulopathy, this is a test of whole blood, not just its ability to coagulate, but the quality of the coagulation. And so it will really help guide your management going forward because you're getting quality, quantity, and time all out of the TEG.
Okay. So if you know someone had been bleeding and then the TEG numbers look favorable, you might say they probably stopped bleeding. We don't have to go so crazy with the transfusions.
Right. And think about your liver patients who are so both prone to clotting and also prone to bleeding. TEG can really help you differentiate whether you have a coagulopathy with that patient that you need to address.
As far as the DOACs go, I heard you tell us a little bit about the reversal agents that were discussed.
Yeah, so there's a couple of new agents that have recently come to market. We've all got some experience with idrisizumab, which is used to reverse dabigatran. But there's a new agent coming to market, which is called adanexin alpha, and it is reversal for rivaroxaban and apixaban, the 10A inhibitors. Mm-hmm. And so there was some talk today about how, although this is a very costly agent, that the risk of thrombotic events on it is about equivalent. It's in the 18% range. And that we can be dosing it appropriately for these agents based on the time that the agent was administered and which agent it was.
Did they mention how expensive that medication was?
I'm sure exorbitantly.
Yeah. Have any of our guests had any experience with the reversal agents for either the direct thrombin or the 10A inhibitors? Anybody?
It has been used absolutely in the ICU whenever we have patients. And again, this brings me up to the previous discussion. If you have an end of life situation with liver cirrhosis, it's actually completely irreversible. Our patient is not a transplant candidate, and we end up using all these agents at the end. The expenses are pretty significant. I mean, we're talking for each vial can be $100,000.
Yeah,
so if you need, it's per weight. So if you need 5, 6, 8 vials, you can do the math. We can be close to $800,000, $900,000. And if it's for a patient that's actually not going to be doing any better, it's just a matter of making the numbers look good and reversing. We need to take that into account, and we tend to forget that part because we just focus on reversing the coagulation.
And it's important to remember that the half-life of the agents that we're talking about is relatively short.
Right.
By the time your patient with bleeding has come to the emergency room and has gotten up into your ICU and is still bleeding, do your math first and make sure that this is something that might be beneficial before you spend your king's ransom.
As a hospitalist, unless I haven't fortunately had the patient who just started pouring out blood on the floor where I felt the need to use one of these agents, and most of the time, it just hasn't even become a thought because the agents are short acting, and usually the patient stops bleeding, or you transfuse them and they stop bleeding, and you kind of just support them through it, which that's kind of just impracticality, but that's probably why I haven't seen it, because in the ICU it's a much different population you're seeing.
Yeah, I mean, I think that what's more useful is to remember that we have to use good transfusion ratios when we're massively transfusing. The trauma patients get the 1:1:1 ratio, but in the ICU, we tend to drift more towards 3:1:1. But when I have experience with this in the real world, I often find that even that ratio is not something that we're keeping up with. So maybe one of the things we can focus on is trying to keep to a more reasonable ratio.
So Chidinma, our new friend, we're going to be hanging out. We're hanging on a lot of chest.
You keep making this threat.
It's great.
And I keep threatening to hang out with you when I'm in LA in the spring.
It's not a threat. It's happening.
Yeah.
The promise.
Good stuff.
All right.
So you went to the critical care update today, and there was a lot of interesting stuff talked about there. Tell us, what do we need to know?
Yeah, so let's continue the family visits, sort of palliative care discussion. And there was a study that they discussed that was out of Brazil, and it was published in the JAMA this year. And basically what it was a liberal ICU visiting strategy versus a restrictive one in patients. So on average, it was like 1.5 hours versus up to 12 hours that the patients' families could spend with their patients. And what they were looking at, the endpoint was delirium, whether or not it helped improve the patient's delirium. They found no difference in delirium when they measured the CAM-ICU, which is a validated scale for measuring delirium in the ICU. However, what they discovered was that secondary endpoints, which was looking at how the families felt, the families significantly had or reported back less anxiety, less depression, and more satisfaction with the liberal visiting schedule. I think this is actually a worthwhile intervention because, yes, it's not reducing delirium, but there's a lot of other positive benefits to doing this. I see myself as an intensivist, not just a physician for the patient. My responsibilities also lie with your family members and making sure that you're okay with this as well, what's happening with your loved one. So if I can do an intervention that causes them less anxiety, less depression, and more satisfaction, why not?
It sounds great. And I think anytime, as you mentioned, in whether it's geriatrics, where someone has cognitive impairment, or if you're a pediatrician, you often, like when the patient can't advocate for themselves, like in the ICU, you are dealing mostly with the family. Mm-hmm. So an intervention that helps them, it just makes sense. I think it's a great point.
Absolutely.
I'm trying to remember where I heard of the model of actually even rounding with the family at bedside. So actually talking about the plan and discussing the patient's update and just having the family right there the entire time. So it's not quite so opaque as to what's happening. They're coming in and just kind of seeing this person in one slice of time as opposed to hearing the actual history, which probably does help clarify things and alleviate anxiety a little bit too.
Absolutely. Yeah, I remember I've worked in a lot of different healthcare systems, and the systems that allowed families to join into the rounds and, respectfully wait till the end but ask questions. The amount of satisfaction they had and feeling like they were actually taking part in the care process was phenomenal. So I would definitely recommend that in institutions that don't do that already. So
at one point, in the talk this morning, when they talked about the end of life, what also impacted the involvement of the family, what impacted the care is the involvement of the family by having a specific dedicated line that the family members could call in. Mm. So the rounding attendant at the end of rounds went on to this app and updated or offered a quick update for each patient, and any family members that were on the list for that specific patient would actually call in and have a full update. That way you did not have the back and forth. Yeah. Hey, the nurse calls you and you're like, what's going on? Oh, well, I have the cousin, I have the sister, I have the mom. Right. And you keep going back and forth. So if you made it available and they could actually share it amongst themselves, that really increased the satisfaction and helped in managing better the care and the patients.
It's always difficult when the family's not available, though, and especially during times that you typically round. Although the times that we typically round are also the times that families are typically not available because they're working, right? And so I think something like that would be a game changer.
Yeah.
You had some other really interesting stuff. Let's hear it.
Yeah. So you want to get into the vitamin C in the ICU one?
It's up to you.
I'm going to set off Stuart, but okay.
I'm kind of a little afraid now. Let's talk about it. Okay, so what I'm talking about is the Citrus ALI study. So that's the acute lung injury study, where basically they randomized 167 patients to get vitamin C versus not, and that's 96 hours after admission. And basically the endpoints, what they were looking at were changes in inflammatory markers. So that's the CRP, as well as changes in the modified SOFR score, which is a sepsis scoring system. They had mortality as a secondary endpoints. For their primary endpoints, they had no difference in the inflammatory markers, no changes in CRP, and no changes in modified SOFR scores. However, there was a pretty significant change in mortality at 28 days. It was 25% compared to 40%, which is huge.
Yeah.
You know?
That is.
And everyone was, they threw up the slides and there was literally like a gasp. People were like, I thought people were going to stand up and start clapping. And then he was like, hold your horses. Let's talk about this. The issue with this is that they had multiple secondary endpoint. And if you know anything about statistics, I know a tiny little bit, when you're doing multiple comparisons, the likelihood of finding a significant difference that's due to chance when it's not your primary endpoint increases. So that was the issue. And, he had written an editorial on it, the presenter, and he had done his own analysis and he discovered that it was actually a 40% likelihood of getting a difference that's significant, but that was actually due to chance when you're looking at your secondary endpoints. It's basically just back to where we were from, in that it's not quite ready for prime time, but there is something there.
Yeah. And go ahead, Aaron.
Oh, but at least it's not steroids. Can we all be just happy about that?
Yeah.
Yes. Well, I wanted to throw this point out there so that if anyone's listening, they might actually be able to formulate a study on this. But one of the things vitamin C is one of those causes for microcytic anemia. And the reason why is because vitamin C reduces ferric to ferrous iron. Ferrous iron is what is incorporated in heme. It's also what's necessary for the hydroxylase reactions to create sympathomimetic neurotransmitters. And the likelihood that ferrous is converted to ferric iron and thus not available is higher in lower pH environments like sepsis and septic shock. And so the IV ascorbic acid actually helps to reduce ferric to ferrous iron and thus allows it to be utilized for the synthesis of neurotransmitters, sympathomimetic neurotransmitters specifically, that which is targeted by like vasopressor agents, right? Vasoactive agents all target the same targets as those sympathomimetic neurotransmitters. And so one of the things I'd love for someone to do is actually do a trial looking at pre and post infusion free iron, looking at ferrous free iron, because that's what our assays check. They don't check ferric iron, right? So you want to check free iron pre and post and look for those who respond, and those who respond should have more of a vasoactive response to vitamin C. And that response should be more profound in low socioeconomic backgrounds. One of the studies that I have underway right now actually shows that African Americans, for example, 2/3 of women of childbearing age are non-anemic but iron deficient, profoundly iron deficient, in fact. Same thing with Hispanics. Caucasians are about 50%, but the Hispanics and African Americans 2/3. And so that needs to be evaluated.
So are you saying we can use IV iron safely in sepsis?
No. I am not saying that. And you have to. So this has not been studied. It's only been studied in mice. So as far as IV iron and the impact in sepsis, but one of the questions is which iron do bacteria respond to? Because they have ferroreductases. They don't have ferrooxidases. So they actually respond to ferrous, not ferric iron. And so one of the concerns is that if you then convert everything to ferrous iron, are you then going to promote bacterial overgrowth?
I bet your heart rate's like 170 right now.
Like biochemistry and translational research is where I live. I live in that gap.
Mm-hmm.
For the listener at home, Stuart's eyes turned completely black during that entire monologue. It was wild.
This is where I live, guys.
Okay.
Great.
Sarah, did you want to tell us about the...
I just, as a comment about the secondary endpoint and the multiple analyses, did they try to correct for that? Because statistically, they should have been able to... there's some controversy about using things like the Bonferroni correction test, but did they comment on that?
Yeah, they didn't do it in the study.
Did they have a rationale for why they did not correct for it? Really?
No. Yeah.
Okay. Just curious. Curious about the stats.
Yeah. So with regards to whether or not it's going to change my practice, for me, it's a little different because, in addition to working in the regular ICU, I'm a burn intensivist. And for burn patients who have crazy fluid shifts, we actually end up using vitamin C quite a bit. So we actually have two relatively, strong indications to use it right now between, trying to not pound them full of fluids and then, potentially helpful in sepsis. So it's definitely not going to be my go-to, but it's definitely something I'll consider if I find I'm, sort of up a creek without a paddle. He's on 3 pressors. I can't give him any more fluids because his lungs are whited out. Maybe I'll consider giving him vitamin C. So.
It almost seems like the pathophysiology would support giving it earlier on before they're on the 3 pressors.
Yes,
but
and the study demonstrates that it's within 96 hours.
Which makes sense based on the pathophys.
Absolutely.
And can I just put in a 2-second aside for all listeners who are not critical care specialists? Normal saline is dead.
Yes, 100%, 100%.
Can we have all a moment of silence for normalcy? It has passed from us, and we are grateful to it, but it is now the era of not normalcy.
Yeah, we are thankful to our surgical colleagues
The
for
surgeons
introducing
were
us to
right.
LR.
Yes.
Okay, Nina, the monocyte distribution width. I just learned about it about 15, 20 minutes ago. Can you tell us a bit about that? Or Nina, I'm sorry. Chidinma.
Yes.
Chidinma, I'm
Yes.
sorry.
So-
Chidinma, can you tell us about the monocyte distribution width?
Well, I have you beat by like an hour. Okay?
Yeah.
Because I learned about it an hour and 15 minutes ago. It's really exciting stuff, actually. And I'm surprised it didn't make much more of a splash. So what it is, monocyte distribution width, or MDW, it's a marker that actually helps separate out sepsis from SIRS. And for those of you just sort of recapping, SIRS stands for Systemic Inflammatory Response Syndrome, where you have your huge inflammatory response and it might not necessarily have anything to do with infection. So what it is, it's actually FDA approved right now, is validated in the ER. It's studied in ED patients. And because especially with the whole 1 hour sepsis bundle, it's important now to actually be able to identify our patients who are septic. And what it is it produces a readout, and they basically validated it where when it's above 20, the sensitivity and specificity for sepsis is incredibly high. It's well above 90.
Wow.
So, yeah. So it's something that it's only available in 5 hospitals nationwide right now, but you're going to be seeing it coming out soon. And it basically comes out as a readout as part of the CBC differentiation. So just as you see your RDW, you're going to see an MDW in future.
Oh, that sounds great. Another number to look at on the CBC, just what I wanted.
Finally. It was getting too easy, so I'm glad they add another dimension.
Yeah, right.
Okay. Well, I think, Sarah, some of the research pearls that you had, we mentioned CRP, we mentioned procalcitonin a little bit on previous. Do you want to let us know about that?
Okay, so speaking of the results of lab studies and interpreting them, I attended a really interesting poster session by Brittany Rosales and Austin Meyer of The Ohio State University. It was entitled Improving the Diagnostic Utility of Clinical Biomarkers. And so what they did is they looked at CRP and procalcitonin concentration, and instead of looking at it as a dichotomous variable with a cutoff point, they wanted to explore what would happen if they looked at it as a continuous variable and whether it would be able to accurately predict the probability of a patient being infected with gram-negative or gram-positive bacteria. So what they did is they took a data set of over 800 people. Ultimately, 188 were confirmed bacteremia. And they found that the continuous percent of PCT, specifically for a value range of 0 to 10, was predictive of gram-negative bacterial infection, but not gram-positive. And additionally, they found that and this I think is interesting, the PCT concentration was not really helpful in this analysis for predicting the gram-positive bacterial infection, as noted, but CRP was not strongly predictive of either. So the CRP continuous variable did not positively predict the infection with a gram-positive nor a gram-negative bacteria. So it was the procalcitonin that actually seemed to have some. Can
you remind me what did they say what the cutoff was that predicted gram-negative infection? Did they give you the value?
They do. They have graphs that I can ask for permission to share in the show notes, but the range of values for the procalcitonin that they gave, or that they emphasized anyway, was 0 to 10. So much higher, obviously, than the cutoff, which I believe is 0.5.
Yeah, 0.5 is a common one that's used. I wanted to ask our esteemed guests, are any of you using CRP or procalcitonin in your practice right now?
So I am. And I say that sort of hesitantly. I see 2 very different populations. I see general medical intensive care unit patients, and then I see burn ICU patients. And physiologically, these are 2 vastly different patients.
Right.
With our burn ICU patients, they come in and they have a massive SIRS response going on. Blood pressure's through the roof, or sometimes hypotensive, tachycardia, it's either profoundly hypothermic or sometimes fever, and it has nothing to do with infection most of the time. until it does. And so the times when it does, we actually draw procalcitonin as part of our order sets because we receive, we're a burn center. So the patients are stabilized and transferred from another facility. Often they have lines in that are probably dirty lines. And we check our procalcitonin. And if it's high, when I say high, I say usually around above 10, then we start antibiotics empirically.
I see.
All right. And this is just more expert practice, anecdotal than anything validated. But we've seen over and over again that in these patients, almost like clockwork, 48 hours later, the blood cultures return positive when the procalcitonin is high. In the medical ICU, I'll say it has less utility. Sometimes it's elevated, and there is, especially in renal failure patients, there is no real reason why, and we don't see infection. And sometimes it's low and there's clearly infection. So I'll say there's a little bit less of a utility for it in that population.
And anyway, Cashlack Memorial Hospital cannot afford procalcitonins.
Right.
And they take 5 days to come back.
Yeah. So it interesting that some places, even when it comes back quickly, there was this article that we'll be talking about on a future show that was in JAMA Internal Medicine. It's one of the medical overuse articles. They do this. They put this series out once a year, and they are recommending not using procalcitonin to say if someone has a lower respiratory tract infection, because clinician judgment has been shown to be pretty much equal for how much antibiotics patients end up getting. So the point of our guest was that they don't think this is a test that's adding value. The sensitivity and specificity are around like 75%. So yeah.
So with regard to procalcitonin in our ICU, we end up using it as a standard initial test for patients that actually have sepsis or are suspected to have sepsis.
Okay.
And we tend to use it to initiate antibiotic therapy and stop the antibiotic therapy when the procalcitonin is not high enough.
Yeah.
The other point I wanted to make is when I did my fellowship, I did cystic fibrosis patients, and we actually did a research study looking specifically at procalcitonin levels in cystic fibrosis patients to determine a CF exacerbation, pulmonary exacerbation.
Right.
And what was interesting, I ran the assay during the, so we got a grant when the PCT was not really available, and we ran the test locally to have it immediately after their admission. And what was interesting is because of the amount of colonization that these patients have in the bronchiectatic world, their PCT level was elevated, not extremely high, but it was not negative. And therefore, we weren't able to actually use it as a determinant factor to whether or not they should get PICC line and 2 weeks of antibiotics or not. So that was really an interesting finding.
And as part of the order set, was that protocolized? Because, and Matt, correct me if I'm wrong, but sort of one of the issues is that even if you gave guidance to physicians using the procalcitonin, they just kind of ignored it anyway. Like, so if you just kind of have it out there as a number without any specific guidance to go along with it, it just didn't seem to be all that helpful. So when you were using it, was there a specific sort of
Absolutely. So we had to actually fight to get the procalcitonin assay in the lab, because you have to add an additional machine to be able to run it and have it back within the hour to be able to determine what to do. So the ICU in the rural community where we are practicing outside of Lansdale and Doylestown went from being an open ICU to a closed ICU. So it's effectively working, if you want, using the procalcitonin in a closed ICU, because you have one captain of the ship that decides exactly what to do. And there was a set protocol that included multidisciplines, ID, the labs, and everybody else, even billing, to figure out exactly whether it would be useful or not. And it turned out to be useful, and it decreases the use of antibiotics within the ICU.
So I think the population, so what I will recommend to our audience is for your general, if you're a hospitalist, if you're a primary care doc, if you're picking up a patient from the emergency department who's not critically ill, I don't think it has a place in your practice.
I don't think I've actually seen one in real life. It's like a unicorn to me. Like I know that, like I've heard them described, but I've never actually seen it.
And that's what the high temp study was looking at, was emergency department admissions and whether or not the procalcitonin helped to guide therapy or not. But there are other studies that look at using it for like antibiotic discontinuation. There's a study from January 2018 which shows that in the procalcitonin group, the rate of superinfection with ventilator-associated pneumonia was 12.5% in procalcitonin group versus 26.9% in standard therapy.
Okay. Any more comments before we move on? We have a bunch more to get to.
Yeah, I can just round out the procalcitonin talk. I'll say we should consider it just as another tool. You know, we all have our clinical acumen and we have a lot of other data points we can look at. The white count, fevers. You can actually do, peripheral. There was a study where they basically used like a little glass to blanch to see peripheral perfusion, and that's actually better than lactate based on that study. So there's a lot of other data points we can use, and I think we can also consider procalcitonin as just one extra piece of information. Don't live or die by it, but just, use it in view of everything else.
Yeah. It's like it's like when you're doing volume status exam, unfortunately, there's no like one measure. You just have to put the history and multiple other things together to make your decision.
Exactly. Yeah.
So Nina, you had some interesting stuff that was kind of blowing our mind in the teaching world. So tell us about this. What should we be excited about?
All right. So this morning, Dr. Carla Lamb, Viren Cole, and Dr. Subhani Chandra actually had a session about technological innovation in medical education. And yes, it definitely blew my mind. So what Dr. Lamb is working on is actually augmented reality. It's a different way to create a virtual classroom for medical students, residents, and fellows. And she had an app that she's developing at this point. It's not available commercially, but she is in the process of finishing and optimizing the app where you are able to use your iPad to recreate virtually the lung based on CAT scan images or just based on the patient being in front of you. And you are able to touch virtually the lung, remove certain segments, localize a nodule as you dive inside the lung virtually. And so when you look at that, the possibility are endless. She is able to create a virtual classroom worldwide where you have 15 students and you're able to interact and take quizzes while actually virtually navigating within the airway. So the example that she gave us this morning was in the classroom, we were literally driving down the main airway and the question pops where it tells you, what am I? And if you get it right, you have a wonderful sound. And if you get it wrong, you get another chance, or the next students end up getting a chance at doing it, and so forth. And so that was absolutely amazing. And that led to the conversation about what are we doing? How effectively are we teaching our medical students, residents, and fellows? And are we limiting them by trying to actually show them or teach them only what we know? With the virtual reality, you are giving them the tools to learn limitlessly. Know what their mind will go based on their vantage points rather than the teacher. Right. And
there's a quote, Paul. Do you remember? I want to say Uncle Bob said this, but it's like, or he sent an article out on Twitter that said this, but it's like teaching is something you do to other people. Education is something you do to yourself. Like you can't, as a teacher, you can't force someone to learn. Like they have to learn on their own. You can sort of inspire them or point them in the right direction, but like it's on the learner to really internalize and work with that information.
And that's what Dr. Subhani Chandra stated during her talk. She said, you have to make it matter. So you can be enthusiastic and try to show them how to do it. Ultimately, she discussed the forgetting curve. They can sit down in the classroom, listen to you, but within 20 minutes, they will retain maybe 10% of the material that you actually presented. And if they forget it and they're exposed to it, and if it's spontaneous on their part to be exposed to it again, chances of them remembering it as time goes on is higher.
Yeah.
And so
I feel like that means I should be a wizard at RTAs right now, and I don't know if that's necessarily the case.
Oh, so true.
So I'm sorry for interrupting, please.
no,
you mentioned, so tell us about this. What if you just drop a computer in a village? Tell us.
So yes,
that's been done, I heard.
The story was really intriguing. So Viren, they were actually discussing a professor in India, in New Delhi, at the end of the 1990s, beginning of 2000, where you were still able to find a remote village that had absolutely no technology whatsoever and no internet. And this professor ended up finding literally a wall where he installed a computer screen with a mouse on the side and connected it to the internet. And he left it there for approximately 3 months. And then he came back. And of course, to his surprise, what he found out, he found actually multiple kids and children all surrounding the screen and literally not only knowing how to manipulate it and save files and go into different sections, but have learned over 600 words and looked at him and asked him for a better processor and a better mouse. And mind you, these children had no idea what technology was about.
They didn't speak English.
They didn't speak English. They're in the middle of a remote village in India.
Yeah.
So that right there shows us how amazing the human mind is. And if we can adopt the same philosophy in teaching medicine to our medical students, fellows, and residents, they're going to end up being better physicians than we are. And as teachers, we ought to encourage better learning techniques and allowing them to be free rather than to be limited in the classroom.
Kim, did you have something to add here?
Just listening to you talk about this is really making me think about the CHEST conference experience and how much they do to get you into that experience and really embracing that gamification theory. So as a trainee here, or not a pre-trainee, not even a fellow yet in pulmonology and critical care, the games that they have, like the Dr. Neb and the COPD challenge and stuff, as opportunities to kind of engage with the material in this low stakes way, but also really taking it on myself has been really fun to watch. And they've given a couple of different talks talking about how games help not only with recalling and remembering what you learn, but also in engaging that learner. And so it's been really cool just being here and seeing like apps to learn how to do bronchoscopy, and as a chief resident thinking about, how am I going to bring some of these games back to my residents?
And to that point also, there are multiple websites and resources to teach virtually. One of them is Bronchoscopy International by Dr. Henry Colt, where literally you have a full curriculum to be able to virtually learn everything needed from the bronchoscopy standpoint. And that's extremely useful, and it's for free. So it's available, and he is amazing at reaching third world countries that have maybe one bronchoscope in the whole town. It's absolutely amazing when you actually are able to learn or train the trainer to learn so much about the bronchoscopies, or train the trainers to be able to deliver better care.
So to round us out here, we are going to talk about Nina's favorite topic in the short time I've known her, which is lung cancer. And Sarah, this is another poster you went to.
Okay, so yes, I attended a poster session. The first author was Dr. Amy Wolf, and the presenter was the second author, who was a medical student at the University of Miami named Kasia Bornstein. And this poster is looking at something that I think is really important to all of us, which is climate change, and specifically the intersection of climate change and its effect or potential relationship to non-smoking related lung cancer. So this study looked at levels of PM 2.5, and PM 2.5 is fine particulate matter measuring less than 2.5 micrometers. And this is a pollutant that's present in the air, but it has been made more common and more of a hazard to people due to the effects of climate change. And those specific effects, I can't really speak on. I'm not super familiar with them. It has to do with like air columns and other kind of climate and environmental science things that I'm not super familiar with. But the end result is that PM 2.5, this pollutant, is now something that people are being more exposed to. They're inhaling this pollutant. So we know that other than smoking, environmental exposure is the main cause of lung cancer. And what they looked at was the correlation between PM 2.5 levels and the age-adjusted incidence of non-smoking related lung cancer, as well as age-adjusted lung cancer mortality. And what they found was that, as I think we can probably expect, that as the levels of this particulate matter increased, it tracked moderately with the increase in lung cancer incidence and mortality. The R-squared values were 0.27 for incidence and 0.31 for mortality. Of course, there are limitations with a correlation study, which Kasia and I were discussing, and Kasia recommends designing a study that compares non-smoking related lung cancer incidence and mortality in areas with and without high levels of PM 2.5 to see if we can get a more kind of robust understanding of what's happening in that relationship. But I wanted to include this in our recap episode because I think it raises really great points about physicians' duty to engage with topics that affect their patients' health and their own health ultimately. So I thought that was a really interesting take on this issue.
Yeah, the whole, small particle stuff. I worry about it working in the city and living near highways. It's something. How worried should I be, Nina? Am I going to get lung cancer? I never smoked.
Well, as I stated yesterday, out of the more than 400 lung cancer that I've diagnosed, 22.6% are related more than likely to something that's probably pollution because most of them were non-smokers.
Right.
And you can see and you can notice that your breathing capacity, your cough, your dry cough is a symptom that's increasing in the inner city environment. And as I stated earlier, I've noted when I worked in the city that many people were having problems with ILDs or IPFs or even sarcoidosis type diagnoses with high lymphadenopathies that are actually not related to anything familiar or genetic, or not even environmental from their daily jobs, such as masonry or anything else like that, but are just living into the city.
The ILD literature supports this too, because there's that wonderful study from South Korea where they measured air pollution over a year's time and they correlated it to acute exacerbations of IPF, and they were able to control for a lot of other factors in that study. So it's very interesting to think that, it doesn't matter what the injury is to your lung. Even if it's just air pollution, it's enough for a lot of patients to have an exacerbation.
Absolutely. And actually, to that point, I see a pretty significant Indian population around Lansdale. And many of them that have lived in a highly polluted city earlier in life come back with diffuse ILD type diagnosis. And when we end up biopsying them using the Envisia, actually, they end up coming up with UIP or just an NSIP or any of the other ILDs. So there's clearly in the population that I see a correlation between, and not recent exposure.
You mean they had been as a child? They were in India. There was a city with high pollutants, and then they
come in and they develop it, and their CAT scans eventually show it because they've never had CAT scans prior.
Alveolar epithelial injury and dysregulated repair. It doesn't matter what the injury is.
Who was that study sponsored by? Was it sponsored by anybody, or Sarah? Do you happen to know?
My understanding with speaking with Kasia was just that this was an analysis that they wanted to do, that they were interested in, and it was publicly available data, I believe.
Sure.
I can confirm that with Kasia since
You smell big pharma here, Stu?
No, I don't think that this was.
So I was looking up what the the in-home air filters, what they are rated against, the size of particulate matter, and they are rated against 3 microns. So anything less than 3 microns they don't test those air filters for. So it's difficult to know whether or not they have been tested or not. So my concern, and this, I'm sure it's not the study, but let's say that some company has tested it and now they're trying to get the FDA or CDC or whatever to say, aha, our filter stops 1 micron, right? And so the next thing is you're going to have another company say, let's test 0.5 microns.
How dare you accuse Sarah's new friend?
No,
being after some air filter fortune.
It just seems very conspicuous that it's right below the cutoff of what's currently validated.
I am not sure sure about that. I can't speak that.
Why
I'm not an
would
air
you?
filter
Not
manufacturer.
Conspicuous is not the word.
But
micron is, as long as you're exposed to pollution.
Right.
Right.
I mean, you're going to be at risk, period.
Oh, wow.
I'm happy to include some information in the show
maybe
notes
you should
about
move outside of
I think we should. I think we should end with this fantastic question by Stuart.
conspiracy theory.
Leave people with this conspiracy theory.
Well, it just and the other thing too is that it seems like the smaller micron particles are fairly well, so that they're more regulated than the larger particulate matter. So, like when you look at exhaust regulation and stuff like that, so it's the smaller particulate matter that's not as well regulated. So I don't know. I mean, I'd like to.
What it's like to be inside that head.
Let's all move to Scotland. We'll be fine.
I've known him 7 years, and he tells me he thinks differently than other people, and I can tell you that has consistently proven to be true. I know Paul now knows this too. All right. Well, thank you to our wonderful guests, our new great friends. Thank you so much. This was awesome. Again,
can I give the one pearl that I learned?
Yeah, sure.
Yeah. So in 1720s, beaver pelts were.
I can't.
Okay.
Fine.
I'm going to stop recording.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get your show notes at thecurbsiders.com/podcast or sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That is correct, Paul, because we are committed to providing you with high-value practice-changing knowledge, and to do that, we still need you to rate, review, and subscribe to us on wherever you get your podcast from.
Yeah, I believe Apple Podcasts these days. iTunes is kind of phasing out now.
Well, and you can contact us at thecurbsiders@gmail.com.
Okay.
Special thanks to our producer for this entire week, Sarah Phoebe Roberts, and to our social media team, Hannah R. Abrams on Twitter, Beth Garbatelli on Instagram, and Chris the Chu Manchu, who is still on ye old archaic Facebook. Until next time, I've been Stuart Kent Brigham.
And Stuart, I'd like to thank you for producing our wonderful theme music. I'd like to once again thank our amazing guests who were so generous to donate their time and expertise. I am Dr. Matthew Frank Watto. I don't know what I was going to say there, Paul. But
This is Dr. Matthew Frank Watto.
This is Dr. Matthew Frank Watto, apparently about to go into full-blown delirium.
You need some vitamin C.
I'm sorry? Oh, whoops, sorry. I was going to make a joke about expanding the ICU hours when you go into your delirium. So, which will make sense when people listen to this. I have been and hopefully always will be Sarah Phoebe Roberts.
Well played.
And I remain Dr. Paul Nelson Williams. Thank you and goodbye.
Oh, hi, Paul.